Okay, thank you. Well, welcome back everybody. Welcome to everybody who is virtual. It's a pleasure to be here, and I'd like to reiterate Lara's thanks to the FDA for this opportunity for us all to meet. My name is Dr. Alan Hakim, and I'm going to be doing the introduction to this next session where we're thinking about living with hypermobile EDS and HSD. That's my introductory slide. I'm an adjunct associate professor in medicine at Penn State in the USA. Go Penn State. I'm a consultant, you put me off now. I'm a consultant rheumatologist and acute physician based in the UK in London, but I'm also the Chief Medical Officer and the Director of Education and the Director of Research at the Ehlers-Danlos Society. It's an absolute pleasure to be here. I kind of feel it's a bit bittersweet. I was thinking about this as I was listening to everybody's stories, which absolutely track and triangulate with my experience of working with my patients in the UK. And I thought to myself, I've been doing this in this field for 25 years. And I kind of feel that we shouldn't have to be here today. But I completely understand why we must be here today. And I think now more than ever, because I feel that we are on the brink of some amazing insights into research and the way in which that translates into therapeutics. But I also think that we are struggling internationally with resources that actually makes the application of all of our knowledge and the treatment and care that people need much, much more challenging than it ever was before. It's a pleasure to be here, but a bitter one at the same time. Right. So my theme's in introduction to this, and then I will get out of the way because this is all about the patient's voice, is thinking about co-occurring systemic morbidities. I've used that particular terminology, but for many of us you would recognize that also as comorbidities. But I think it's important to remember that there are many morbidities that are directly associated with hypermobile EDS and HSD in their own right, and then there are a number of other systemic morbidities that are very, very strongly associated with which we are gradually learning more about causation. Impact on daily living, access to healthcare, and separate to access to healthcare, access to treatment, because I think those two different things are very different for different reasons. So thinking about the co-occurring systemic morbidities, the first message I want to get across is that this affects people of all ages. It can be relatively easy to assume, given the amount of literature, the nature of the literature, and the way in which we present a lot of the work that we present, that this is more the younger adult, but actually it profoundly affects children and adolescents, and it profoundly affects people of an older age too, and in many ways for different reasons. So I want us to be reminded that this affects people of all ages. And that has implications for healthcare provision and social care provision in different ways for different community groups. The spectrum of disease severity and the impact on function has an enormous impact on quality of life, and you've heard some of this already today, and you will undoubtedly hear more. Universally, amongst the symptomatic patients that we look after, acute and chronic pain is present in one form or another, varying in degree, and often incredibly debilitating. And if it's not acute or chronic pain, then it's chronic physical and or cognitive fatigue. These are right up there as the two most prominent morbidities for the vast majority of our symptomatic patients. Alongside that, though, you've heard already of a number of the multiple co-occurring morbidities that fluctuate both in their severity over different time, but also in their combinations and their complications. And for some patients, it can be something on one day, and for the same group of patients, something completely different on another. And this is very, very challenging for people in terms of managing their chronic disease, the fluctuations between the multiple co-occurring conditions. And then it's important for us to remember that that it has an impact both physically and mentally on somebody's health and well-being, and we've alluded to some of that in the context of the Odyssey in terms of a diagnosis. Now, I've shown this slide a few times before, but I keep on bringing it up because it's some relatively new data that was first shown last year at our scientific symposium in Rome. And it's a cohort data from a huge global registry that was established by the Ehlers-Danlos Society, which demonstrates across the different types of EDS, in this case hypermobile EDS, classical EDS and vascular EDS, and also HSD, the prevalence of reporting of these comorbid concerns. So on the bottom of the graph, you'll see fatigue and GI, headache, anxiety, depression, dysautonomia, gynecological concerns, bladder concerns, mast cell activation disease. These are all things that we have been discussing and will be discussing further. And on the y-axis, you can see the percentage of people within this global registry who have reported these kinds of symptoms. And the different coloured bars represent the different diagnoses between HSD, purple, hypermobile EDS, yellow, classical EDS, blue, and vascular EDS, red. And a few observations here. First of all, it doesn't really matter which of the different comorbid concerns you're looking at. Pretty much all of our patients are reporting similar kinds of prevalences regardless of diagnosis. And secondly, you can see across this breadth how profoundly prevalent many of these symptoms are, ranging from 30 to 40% of our patient cohort all the way up to 80 to 90%. And I haven't put pain in here because it would basically be a bar at the top, 100%. Now, the other thing about this data that we can show, which I think reflects some of the issues around the diagnostic odyssey and also access to care and access to treatment, is that these conditions don't just sit in isolation of each other. Most of our community experience a number of these different disorders at the same time to varying degrees of severity, both across their day, across their week, and across their month and year. And this particular chart, looking at that data from the global registry, essentially shows that if you look at the top 5 major concerns, GI concerns, pain and or fatigue, allergy and immunology, anxiety disorders and dysautonomia, you can see that for over 75% of this entire patient cohort, there is a reporting of 3 or more comorbid conditions at the same time. Now, this doesn't reflect all of the comorbidities, and many people have many more. And this is a hugely challenging issue for patients. It's a hugely challenging issue for their clinicians. So what about the impact on daily living? So I've alluded to the fact that there's variable severity, both between individuals and in an individual's case, both in HEDS and HSD. And this can be difficult for individuals to manage because it can be very unpredictable. Significant impact on function, activity, and quality of life. I'm always struck really by the considerable resilience, nevertheless, in individuals with hEDS and HSD in our community. Many, many, many patients of mine, I believe, are able to manage the complexities of this far more than I ever could imagine myself being able to. Nevertheless, there are significant adaptations that they make to their daily living in order to be able to cope with their health concerns, and it becomes for them their new norm. And their new norm is nowhere near normal when you compare it to the general population. And I think that's very important for us to recognize. It might appear to be a good day, but it ain't a good day by any stretch of the imagination if you compared it to somebody who didn't have these concerns. And the symptoms can be so debilitating as to render somebody housebound or possibly even bedbound. And this can occur at different times for an individual, or it may actually be the norm for them in terms of the severity of their disease. And in a small number of cases, notably in GI failure, the sad truth is that it can be life-threatening, and we've actually seen some people lose their life. So the impact on daily living is enormous. It's daily living, and it would affect all of these different things. Your ability to socialize for various reasons, whether it be physical, whether it be emotional, depending on what's going on with your health that day. Environmental, because it may be that you have mast cell activation disorder, and that actually going into any environment where there is carpet cleaner or somebody wearing a fancy spray, it just makes it impossible for you to manage. Normal daily activities can be extremely difficult for some people. Sleep can be very challenging, and we know that sleep is fundamentally important for all sorts of reasons in terms of health and well-being. People have to make adjustments to their diet because of their gastrointestinal concerns. Learning, we've heard some examples already today of where there have to be adaptations in order to be able to give somebody the opportunity to learn, to get the best out of their schooling, college, university, their professional training. Employment. This can be very challenging for some people, and there needs to be lots of adaptations thought through, and a lot of people in our community are unable to work and therefore rely on national allowance schemes of different types. Travel can be extremely challenging for people, and I'd like that to be borne in mind in terms of actually accessing their healthcare or accessing their treatment, as can tolerance to treatments. We've heard about an intolerance to some of the physical treatments, but there are intolerances also to medicines and various other things, in part because of the incipients in them if you have allergic tendencies. So these things are all areas that I think impact people's lives. Then there'll be many more, but these are my reflections from my conversations with my patients. So what about access to healthcare? Well, I think that the boundaries to this include that I think a number of clinicians are just not familiar with or feel confident in making the diagnosis of hEDS or HSD. Access to multidisciplinary teams is limited, and we've talked about this a lot. But I'd like us maybe in our conversations to reflect about how this is very similar for long COVID patients, for chronic pain patients, for chronic fatigue services, and that actually when I talk about there being limited resources, there probably are combined resources that could all be extremely valuable because those resources are limited, but the expertise in them is universally useful to a huge number of our patients, regardless of the diagnosis. Practice license rules across states, national boundaries, these limit the access to experts. Distance to travel, as I've alluded to, although this may become something that is more manageable with an increase in networks and centres of excellence. Often there's a need to be under a number of different clinicians, and they may be in different places. Often I think in the USA, from what I've heard, in different states. And this is incredibly challenging for people. And I think it's also compounded now by the loss of the virtual consultation, which we all learned was incredibly valuable, I think, both as clinicians and as patients during the COVID-19 pandemic. And systems have reverted to norm, and we are nowhere near normal in this kind of circumstance. And so there are technologies, and there are processes, and there are previous inverted policies, if you like, or reverted policies that allowed us to practice much, much more effectively that have actually been lost as we revert back to our pre-COVID-19 pandemic way of working. Access to diagnostics. In the future, we need to be ready for genetics, epigenetics, metabolomics, but we already have a problem with access to genetics if you think that there may be a differential diagnosis to be considered. We already have a problem with access to imaging and laboratory investigations, even if you are a willing and knowledgeable clinician who wishes to do this assessment. The other issue is, as we've discussed, clinicians' personal or even healthcare organisational refusal to see individuals with hEDS or HSD, which can be made much worse by specialty organisation guidelines that actually have encouraged people to dismiss referrals. This is very real. It's an issue that I have in the UK at the moment that we are grappling with. And one of our major organisations actually has a letter that tells the clinicians in that specialty to not see patients and to refer them back to their general practitioner. Personal finances, employment, workplace insurance. Many people are on national allowance schemes, as I said, for their support. So financially, this is a boundary. And healthcare policies for complex chronic disease. of themselves can be a boundary in not being able to provide sufficient cover. So in my last 2 slides, I promise, access to treatment. So I think particularly over the last 6 years, 7 years, there has been an explosion in our knowledge, awareness of the role of therapeutics and the value of therapeutics as we understand more about the causality and we have more evidence base from case control trials and large cohort studies for treatment. This is absolutely adding to our best practice evidence base, and it's really necessary that we share that knowledge as much as possible to try and stop the conversation that goes along the lines of there is nothing that can be done for you. For all the morbidities, clinicians treat with the available medications and other therapies that are actually already available in other clinical scenarios. We are constantly reaching for different therapeutics, knowing that they are of value and have been demonstrated to be of value in other similar disorders. We do not have a significant amount of evidence that is specifically relatable to hypermobile EDS and HSD. So we're borrowing from colleagues in other disciplines. And in some cases, we have to recognize that these treatments aren't actually licensed for the specific purpose, but nevertheless are clinically appropriate. And this limits access to use by non-specialists. It can only be prescribed off-label by a specialist. And even then, that might not be possible for the individual, or it might not be acceptable from their insurer because of the lack of approval. So summing up, I think that we are in a world that is very similar to other chronic diseases, and I note a very recent powerful and emotive FDA meeting that I had the privilege of joining virtually that was on long COVID, where individuals shared many of the identical concerns to those experienced by HEDS and HSD in our community, and I think some of that learning from that meeting and others undoubtedly will triangulate and echo what we're talking about today. And my call out is really to identify ways to make assessment and medications and other therapies as easily available to the EDS and HSD community as possible, whether this be, for example, drug repurposing, clinical guidelines and service resourcing, fast-tracking innovations in therapies and clinical trials, and addressing the inequity in access when it is often based on financial capability, insurance status, or the strength, if you like, of your insurance policy. So with that, I thank you for listening, and I hand over to my patient colleagues.